Implantation of a reverse arthroplasty in patients with proximal humerus fractures requires a specific surgical technique. The two most important principles for this procedure include placing the stem in the adequate height and version and obtaining sound fixation of the tuberosities. The success of the procedure is facilitated by use of a dedicated fracture stem as well as fracture-specific instrumentation. In this video, we will demonstrate surgical reconstruction of a right proximal humerus after fracture using a reverse arthroplasty. This 80-year-old female patient sustained a complex right proximal humerus fracture. Plain radiographs show substantial comminution and displacement. Careful evaluation of the CT scan with three-dimensional reconstruction shows a fracture fragment involving the lesser tuberosity, a second fracture fragment that includes most of the head and the greater tuberosity, and substantial displacement and comminution between the humeral head and the shaft. Two-dimensional imaging also demonstrates the compromised bone stock of the humeral head. Our preference is to perform the procedure in the so-called beach chair position through a standard long deltopectoral approach. In our experience, a somewhat lateral skin incision facilitates exposure. A medial skin flap is raised to identify the deltopectoral interval proximally. A Hohmann retractor may be placed over the tip of the coracoid to aid with exposure. The deltopectoral interval is then developed from proximal to distal, taking care to preserve the cephalic vein, which is typically retracted to the medial side. A second Hohmann may be placed under the humeral shaft, and a combination of blunt and sharp dissection is used to mobilize the deltoid and divide any thickened bursa. The space between the conjoint tendon and the surscapularis is developed as well, and the claviopectoral fascia is divided to the CA ligament. Our preference is to perform a biceps tenodesis in every reverse for fracture. The biceps tendon is easily identified in the basidial groove. It can be tagged for later tenodesis and divided. Dissection along the course of the biceps tendon will lead to the so-called interval region. The biceps tendon can then be partially resected and the interval completely divided to the glenoid rim. Next, the tuberosities are mobilized and controlled, and the fractured humeral head is resected. In the majority of the cases, the fracture plane is lateral to the basidial groove. A periosteal elevator may be used to gently open the fracture site. Any fragments of bone found during exposure are saved for bone grafting later. The lesser tuberosity is then identified and controlled. An automatic clamp may be used to grasp the lesser tuberosity, and one or more traction sutures are placed through the surscapularis lesser tuberosity junction to aid with control of the lesser tuberosity. In this particular example, the head segment is still in continuity with the greater tuberosity. As mentioned before, any free fragments of bone are saved for bone grafting later. It's important to identify the correct plane between the humeral head and the tuberosity in order to remove the humeral head completely, but at the same time save the bulk of the greater tuberosity. Not uncommonly, this requires removing the head segment in a piecemeal fashion. The humeral head pieces are saved for use as bone graft later in the procedure. Use of color-coded, non-absorbable sutures is extremely useful for tuberosity reconstruction. In this particular example, we're going to place two blue-colored sutures around the greater tuberosity at the junction between the supra and the infraspinatus muscles, and two additional white-colored sutures inferiorly, again around the greater tuberosity at the junction between the infraspinatus and the teres minor muscles. Additional sutures may be placed in between these two pairs of sutures in order to provide traction and control the greater tuberosity. Some surgeons prefer use of so-called Nice knots. Note that we're now demonstrating a left shoulder fracture in a different individual. A suture is being placed around the greater tuberosity to shadow the sutures that will be later used to fix the tuberosity using Nice knots. The sutures are passed so that there will be loops on one side of the tuberosity and two free ends on the other side of the tuberosity. Two sutures may be passed superiorly together and a second set of sutures may be passed in the same fashion inferiorly. Humeral preparation requires distal rimming and proximal broaching to be able to place the real component in the right height and version. The proximal aspect of the humeral shaft may be exposed by placing the shoulder in extension and external rotation. Bone fragments are removed and saved for grafting later. The humeral canal is then sequentially rimmed in 1 or 2 mm increments until there is relative tightness of the rimmer in the canal distally. However, the absence of proximal humerus makes it difficult to trial properly. Our preference is to use a dedicated trial system for fractures. In fracture situations, it is difficult to achieve adequate fit of the broach because of the width of the canal distally. This particular trial system has an expandable mechanism that is activated by a proximal wrench. Turning the wrench clockwise will expand the two halves of the broach, achieving adequate stability of the trial. This allows adequate selection of the humeral bearing thickness as well as confirmation of tuberosity reduction. The broach handle is connected to the expandable trial with the right degree of version marked with a version rod. This close-up view shows expansion of the stabilizing mechanism. Our preference in fracture cases is to implant the stem in 20 degrees of retroversion. The height of the trial will be determined by a combination of preoperative planning and intraoperative trialing as well. Most of the times, the medial aspect of the fracture line is very close to the medial aspect of the flare of the humeral broach. Note how once the expandable mechanism is secure, the broach is stable enough to allow trialing and selection of the thickness of the humeral bearing. Exposure of the glenoid is somewhat straightforward in fracture cases. Our preference is to implant the baseplate component of the reverse prosthesis flush with the inferior bony glenoid rim and with approximately 10 degrees of inferior tilt. Once a glenoid guide has been inserted into the glenoid vault, rimmers may be used. Care must be taken to avoid excessive rimming in fracture cases due to the lack of subchondral sclerosis. When using central screw-based components, it is important to use a screw that will be slightly longer than the length measured. With modern component designs, it is possible to combine bone preservation and excellent primary stability by using locking compression screws. As long as the central screw gains bicortical perches, it is possible to obtain adequate stability even in patients with marked osteopenia, commonly present in fracture patients. Fixation is then augmented with multiple peripheral screws. In order to avoid excessive tension on the tuberosity repair, our preference is to use a non-lateralized, non-eccentric glenosphere in fracture cases. It is extremely important to confirm secure engagement of the Morse taper. Once the glenoid component has been implanted, retractors are removed, taking care not to damage the sutures that were placed around the greater tuberosity. The proximal aspect of the fractured humeral shaft is again exposed by placing the shoulder in extension and external rotation, and the selected expandable trial is placed in place and locked. A trial humeral bearing is then assembled and the joint is relocated to assess for range of motion and impingement, and more importantly, to confirm adequate reduction of the greater tuberosity. When cemented fixation of the humeral component is planned, it is important to place the restrictor prior to placement of additional sutures through the shaft. Once the cement restrictor has been inserted, a drill is used to perform 2 cortical perforations for placement of sutures that will be used for vertical fixation of the tuberosities. 2 sutures are placed so that the needle will be left facing posteriorly with one of the sutures and facing anteriorly with the second suture. Alternatively, sutures may be placed with a loop configuration for use of niche knots. Multiple techniques have been described for fixation of the tuberosities at the time of reverse arthroplasty. In this animation, we will demonstrate a 6 suture technique using niche knots. The same configuration may be used for simple sutures. Of the 2 green and 2 blue sutures initially placed around the greater tuberosity, 1 green suture and 1 blue suture will be used to fix the tuberosity to the stem, whereas the other green suture and blue suture will be used to fix both tuberosities. Here you can see how one blue suture inferiorly and a green superiorly are placed through the holes of the stem before stem implantation. Once the glenoid component has been secured in place, the other two green sutures superiorly and blue suture inferiorly will be passed through the suprascapularis and around the lesser tuberosity. Note how of these 4 sutures, 2 will be used for fixation of the greater tuberosity to the stem, whereas the other 2 sutures, so-called around the world, will fix both tuberosities together. Finally, the 2 vertical sutures placed through holes in the shaft will be used for vertical fixation of both tuberosities. It is typically easier to pass the sutures around both tuberosities before implantation of the humeral component. One of the 2 low white sutures has already been passed around both tuberosities. The second low white suture will be saved for pass through the hole of the stem. The next blue colored suture will again be placed around both tuberosities, and the last superior blue colored suture will be placed through a hole in the stem. The stem is then brought to the surgical field, and the inferior suture is placed through the inferior hole, where the superior suture is placed through the superior hole. The stem is then held up in space by a surgical assistant, taking care to avoid suture tangling or damage through component implantation. Current standard of care is to use cemented fixation. Cement is inserted only on the lower part of the canal, whereas bone graft is packed tightly on the upper part of the canal. The humeral component is then driven through the bone graft and into the cement column and inserted to the exact height and version that was selected using intraoperative trialing. Once the cement is completely cured, the real humeral vein is impacted on the upper portion of the humeral component. Care must be taken to avoid trapping the greater tuberosity behind the humeral component. This is facilitated by placing the arm in abduction and by using a periosteal elevator to lever the tuberosity over the shoulder of the component prior to relocation. With the arm in abduction and external rotation, the 2 sutures that secure the greater tuberosity to the stem are tied. In this particular case, there wasn't a space between the greater tuberosity and the stem to place additional bone grafting. Bone graft obtained from the resected humeral head can be then packed tightly around the upper portion of the exposed humeral component before fixation of the lesser tuberosity. Lateral traction may then be applied to the lesser tuberosity, and the 2 sutures that were placed around both tuberosities are tied sequentially, completing our circumferential tuberosity fixation. Once secure horizontal fixation of both tuberosities has been achieved, any traction sutures that were used in the case may be removed. The use of knee knots is demonstrated as an alternative in the left shoulder of a different patient. A single surgeon's throw is placed and the 2 ends of the suture are passed through the loop. This suture configuration provides 2 stands of suture at the same level and allows sequential tightening. The knot is then secured with multiple reverse half hitches. Knee knots are difficult to use if the sutures used for tuberosity fixation do not slide. We return to our case to demonstrate vertical fixation of both tuberosities with the sutures that were placed through the shaft. This is the suture that will be used for anterior fixation of the lesser tuberosity and the suprascapularis. Several throws are passed through the suprascapularis tendon substance and tied. The other suture that was placed through holes in the shaft will be used for fixation of the greater tuberosity vertically in a similar fashion. Care must be taken to avoid accidental damage of the other sutures with the needle used for vertical fixation of the tuberosities. When adequate horizontal and vertical fixation of both tuberosities has been achieved, the surgeon should be able to move the shoulder under direct vision with no macro motion of either tuberosity. At the end of the surgery, the long head of the biceps tendon may be sutured to the conjoint tendon for biceps tenodesis. This allows secure fixation with multiple sutures of the long head of the biceps to the short head of the biceps. As an alternative, the long head of the biceps may be secured to the pectoralis major with multiple sutures as well. 1 gram of vancomycin powder may then be sprinkled into the surgical wound in an effort to decrease the rate of deep infection. The delta pectoral interval is then approximated with a few interrupted sutures, and the rest of the closure is routine. These are the x-rays of a different patient that sustained a complex proximal humerus fracture approximately 2 years ago. X-rays obtained at week number 6 show adequate implant position and tuberosity fixation. At 2 years, there is no evidence of mechanical failure of the implant, and both tuberosities are healed successfully. This is the active range of motion achieved by this patient 2 years after reverse force fracture. Noticed excellent elevation and forward flexion, as well as excellent active external rotation only achieved with adequate union of the greater tuberosity.